hospital in Canada. I have a background in global health. I've done some work in Addis in Ethiopia, as well as Kampala, Uganda, and Lima, Peru. And so I'm hoping to get involved in more of the ECHO sessions and learn how to run some. So thank you so much for having me here as an observer.
Thank you, Kyla, for introducing yourself. Okay, now welcome to all participants and faculty. Today's session of the ECHO on palliative care for humanitarian health workers. Today is our third session and is on the topic of Introduction to Palliative Care. I am Lailatul Firdaus, Senior Staff Nurse from Department of Palliative Medicine, Bangabandhu Sheikh Mujib Medical University, Dhaka. For just a few reminders for today. Today's session, please do not hesitate to ask any question in the chat. We have several faculty members who are monitoring you in the chat, and to respond in your question, we want to make sure that you understand everything. You can ask your question in Bangla also. We have several Bangla faculty here who are watching the chat also. So please feel free to ask any question. Yeah. A few etiquette for Zoom points, because please make sure that you are on mute unless speaking. Use chat for question and discussions. If your audio is poor, then we suggest switching off your video. Now, I would like to introduce our first speaker for the session, who is Dr. Hunter, Director of Palliative Care, Washington Hospital Center, Washington, DC, USA. Over to you, Dr. Hunter. You have 20 minutes. You will get a 1 minute warning before your time is up from site.
All right, thank you. Thank you. I will look out for that warning. Good morning, everyone. My name is Hunter Groninger. I am a palliative care physician, as Lila said, in the United States, in Washington, DC, at a large hospital called Washington Hospital Center. I had the pleasure of going to Bangladesh and to Cox's Bazar in the very beginning of 2020, right before all the pandemic started. So I was really excited to have that experience and to be able to get a sense of the environment there and the palliative needs there. And we'll start to talk about some of that today. What I'm going to do, I'm going to share my screen and we'll just get going. So I'm going to ask maybe Catherine or Layla, can you see my screen?
Yes, we can see your screen.
All right, so here we go. What I'm going to cover today in about 20 minutes is an overview of the field of palliative care, the philosophy of palliative care, and we will just touch on today what is this field, who needs this kind of care, and how can we begin to think about delivering it. And while I talk, I really invite you to think about the clinical work that you do, think about the patients and families that you serve where you work, and think about some of the themes and content that we'll talk about here and how this might apply to your patient population today. So after a lot of this is repetition from the video session, and I did that on purpose because I don't know if everybody could get a chance to see that. So I will cover as much as I can in my allotted 20 minutes. And then we'll move on to the next part of the teaching today. But I hope after today, you will be able to define interdisciplinary palliative care. You will be able to explain who benefits from palliative care services. And you will begin to discuss different ways that palliative care can be delivered to different patient populations. And this is where you start to think about how you can start to incorporate this care into your own work. So let's start with the first step. What is palliative care? So here's a case example. This is actually, this is not the patient himself, but it is very similar to a patient that I encountered and Dr. Catherine encountered when we went on our trip to Dhaka before Cox's Bazar. A 67-year-old man with terminal chronic obstructive pulmonary disease, or emphysema, was living with his son and 2 grandchildren in one of the Dhaka slums. He had one bronchodilator to use to manage his COPD. He spent most of the day on a bed that he shared with the rest of his family, and his symptoms that we could assess included severe shortness of breath, a moderate cough, and mild pain in his chest wall. And for most of the visits, he was weeping. He was crying for most of the visits, and he really wasn't able to tell us why. So I'm going to take 1 minute now and ask people either to speak up or to enter into the chat. What are some sources of suffering that you might identify in what I've shared with you so far? And I don't think there are any wrong answers, so I really encourage people to think about this. So we'll take 1 minute and see what your thoughts are. What might be some ways that this patient is suffering?
Okay, the patient might be suffer due to his dyspnea, due to his actually the medicine support, and also though he is a old age person. So if he belongs to not a solvent family, then it's also they think that it's a burden disease for them also. And after the end of the life, actually, they, as you mentioned, the two branches in Islam. So some of the stigma is also there. They might be communicable. So there is several that they suffer actually from psychological and social and also economical. These all are things that make the person suffer actually, I think.
Great, thank you for sharing those thoughts. I could hear a lot of that through, and thanks for some folks putting things in the chat as well. He's suffering physically, economically, that's true, and I think Dr. Mudral was mentioning, the impact on the family as well, and what this is like for them. His bronchodilator is not well controlling his disease. That's great, true. Any other thoughts? These are all great thoughts. And the truth is that for this patient, there are a lot of ways that he is suffering. He has a symptom burden that is unaddressed or maybe under-addressed that we want to work better to help him be more comfortable. We don't know what communication has happened with him or with his family about his disease state, or his prognosis. How long is he expected to live with this disease, and what will end of life be like for him and his family? He's at home right now, and we don't know yet if this is where he prefers to continue his care. Is this something that is possible to be able to stay at home, or will he end up needing a higher level of care and have to move from his home, maybe lose that connection, that direct connection to his family? And then finally, one of the challenges that we always have in end-stage emphysema and in many other diseases that we see in palliative care is that there's a lot of unpredictability about what will come in the coming days and weeks. Things change and can change very quickly, so it can be challenging to counsel patients and families about what to expect. And that's the reality of the illness experience, that as much as we want to be able to predict what will happen over weeks or months with an advanced illness, the reality is that no matter how long one has practiced medicine or clinical care, we're not very good at predicting death very accurately. This is an old study that really kind of strengthens this point that while on the green line, we may think of cancer, and specifically solid cancers, as something that progresses over time, and we can see an individual's decline and somewhat predict maybe when end of life will occur. But for many other disease states like congestive heart failure, like dementia, like emphysema, that's very, very unpredictable. So if we're waiting to be absolutely certain that someone is entering a terminal phase of a disease, we may have missed some really important opportunities to provide holistic supportive care. And as you all have already started to talk about, this does not just impact the patient, it impacts the family as well. There are emotional and spiritual support needs to caregivers, financial burden, someone brought that up for the case. We need to provide education about how to do best caregiving to families. People don't necessarily know how to do this complex caregiving in the home setting. And again, thinking about some of the complexities of where we can deliver the best healthcare possible in these situations. So here's a definition of palliative care that the World Health Organization uses, and it's a helpful way to ground us today. So this was our first objective. Palliative care is an approach that improves quality of life of patients and their families facing problems associated with life-threatening illness through prevention and relief of suffering. And we'll talk about different domains of suffering that you all are already bringing out in the conversation today: physical suffering, psychosocial suffering, and spiritual suffering. And those are all things that we want to try to address through interdisciplinary palliative care. And the reason for this is because, as we were talking about with this case, someone with a chronic or a life-threatening illness may have physical concerns such as pain and other symptoms, psychological distress, sadness, worry, anxiety, spiritual distress. Important questions. Why is this happening to me? I'm a person of faith. I'm very active in my religious practice. Why is this happening to me? Why am I suffering here? And social needs, basic needs for food or shelter, financial assistance, getting medications, all of this plays into the illness experience. And when people have an incurable illness, like emphysema, like cancer, like heart failure, people want their pain and other symptoms controlled. They want to feel like they're more in control of a situation that feels unfixable. They want to relieve any burdens on their families. They want to have an opportunity to strengthen relationships with their loved ones. And when we really counsel patients and families about what's happening and a situation that we cannot fix despite our best medical interventions, people generally want to avoid an inappropriate prolongation of the dying process. They want to have choice about where their end of life takes place and what that is like. And we need to respect those wishes. And because of that, it's really important that we engage in a type of palliative care that can happen in parallel along with other disease therapies. So part 2, who needs palliative care? The World Health Organization has a global estimate of palliative care needs worldwide. I'm not going to talk about all the different disease states that are on this slide, but I share it with you just so you can see that while many people think of palliative care associated primarily, let's say, with cancer, that there are many other disease states that can really benefit from this kind of holistic supportive care. So start to think about your patient population and their underlying diseases and how palliative care might be a really good fit to help support them through their illness experience. Who needs palliative care? Again, many different disease states have been shown to benefit from this kind of care, not just cancer, but also neurological illnesses, people with strokes, people with spinal cord injury, people who have experienced different forms of paralysis, end-stage organ disease, lung disease, kidney disease, heart disease, liver disease, people with HIV/AIDS, and then children with congenital anomalies or genetic conditions. There are many different disease states that might benefit from the type of care that we're starting to talk about today. So start to think outside of the box or outside of what we traditionally think of for palliative care in terms of the patients and families that will benefit from it. And here are some numbers that I've learned about, and you may know the more accurate numbers than these presented here today. But my understanding is there are an estimated 600,000 patients in Bangladesh who are in need of palliative care each year. Of those patients, 200,000 patients are diagnosed with cancer annually in Bangladesh, and almost all of those cancer patients are incurable at the time of diagnosis, an enormous need for the type of services that we're talking about today. So we talked about the disease state, and we talked about different patient populations that would benefit from it. I want to conclude this part by talking about when we can provide palliative care. Many people think about it only as a time of when people have a very limited prognosis, days or weeks to live. But we're learning more and more that palliative care can be provided for months or even years through the illness experience. It has been shown in medical studies not to speed up death, but actually to improve quality of life for our patients, and it can and should be provided at the same time as other appropriate disease therapies, such as chemotherapy for cancer. The World Health Organization recommends palliative care from the time of diagnosis of life-threatening conditions, much, much earlier than many of us think of it. Finally, how do we start to provide palliative care? I'm sharing just a glimpse into the discipline itself and the ways that we can begin to serve patients and families. How do we actually start to do this? Here's an example of a way of thinking about types of palliative care provision. At the bottom, a palliative care approach is something that any healthcare provider can do. When you start to ask your patients about how they feel symptomatically, what's important to them, what are their life goals, where do they get their support from, where do they get strength from, you're practicing some palliative care right there. Through this course and through your own professional experiences and mentoring, you may develop skills in what we might call general palliative care, being able to learn more strategies around pain management or symptom management, how to engage in complex communication about diseases or end-of-life care with patients and families. And that might be more generalist palliative care. And then particularly complex cases, you might refer to a specialist palliative care team, someone who is devoted to this 100% of his time or her time, or someone who has done special training in palliative care. And there are many faculty, internationally and locally to Bangladesh that are on this in this call here today that can start to be resources for you. Where can palliative care take place? Again, I want to emphasize it can happen anywhere where the patient is. Certainly in the community or at home with sort of a public health approach. I was really excited to see the model of community health workers in Bangladesh. That's something that it was really new to me and really important for me to learn about. But certainly palliative care can take place in hospitals or in clinics or other health facilities. And depending on the location, on the geography, there are hospice organizations or hospice facilities, specialized facilities where patients can get palliative care really focused in general at the end of life. That may be of limited availability in Bangladesh today, but maybe something to work on together in the future. I'm going to just conclude with this thought, and then I'll turn it over to Dr. Catherine and Layla for the next part of today. Palliative care to me is really a mission. It's something that we're called to do. And I really like this quotation from Dame Cicely Saunders, who I often think of as a founder of the modern hospice movement in the United Kingdom in the West. She said, go around and see what's being done, and then see how your own circumstances can produce another version. There's need for diversity in this field. And I really think of this as a call to action where you are. You're here today to be engaged in this field, to learn about it. And I hope to take this knowledge and skills back to your work and engage with your patients and families and your other colleagues to really change the culture of how we take care of patients with advanced illness. That's all that I have to share with today as my summary, and I will stop here and turn it back over to Layla. Thank you.
Thank you, Dr. Hunter, for your nice and informative presentation. Does anyone need any clarification in Bangla of any points? Okay. Now we have a few minutes for questions and comments from everyone. If you would like to ask a question, please raise your hand or unmute and ask your question. Or if you would prefer, you can type your question in Bangla in the chat box also, and I will read it out. Ashraful Rahman ask, please explain how palliative care helps renal, cardiac, liver, and premature children. So Catherine replied, palliative care can help people with the end-stage organ disease by improving physical and psychological symptoms, communicate with the patient and family, and help with planning for the when patient becomes sicker. Similarly, palliative care can help neonates also and children and their families with the life-limiting and life-threatening illnesses. So please go ahead with the questions. If anyone asks, you can ask by unmute yourself.
Leila, could I just add an extra comment on that while others are having a think? So, Dr. Meridol, are you asking a question? Because it's a bit fuzzy, we can't quite catch you. Anyway, I'll carry on with my comment, and please do come back in, Dr. Meridol, or write in the chat if you're asking a question. The connection was a bit poor, so we didn't catch it. So just to say, it's a really good. Oh, I'm not sure if you're coming in or not. Anyway, just to say, it's a really good question to see how palliative care can help other disease states beyond maybe cancer, which is a classical one that people think about. And what's quite nice about palliative care is that regardless of the condition, which as Dr. Hunter explained, there's different groups of conditions that may benefit from palliative care, different groups of patients with life-limiting illnesses, life-threatening illnesses that may benefit from palliative care. Regardless of the disease type, palliative care, the approach to palliative care is similarly across the different disease types. So as Dr. Hunter explained, we focus on the physical symptoms, communication, support for patients and families, and care planning. And these same aspects of palliative care are present whether you're looking after children, neonates, or adults with different types of illnesses.
Thank you, Dr. Catherine. Nazmul Haq asked how to help palliative care for chronic wound patients who could unable to move. So I am requesting Dr. Hunter, if you clarify the what are the patients and what type of patients we can just help palliative care patients, what type of patients?
Sorry, Leah, can you repeat the question?
Nazmul Haq asked how to help palliative care chronic wound patients who could unable to move.
Sure, thank you. That's a great question. How can we help with patients who have chronic wounds? I think that is a topic that we will cover in more detail later in the course. Dr. Catherine and Leila, you can remind me if that is true. For a brief answer here, I'll share that if patients who have chronic wounds often have pain related to the wound, and the pain can interfere with sleep, activity, well-being, socializing. So pain management can be very important, helping the wound not to get worse and maybe to try to heal. That's something that palliative care can also help with. Many chronic wounds, especially wounds from underlying cancers, can also have a really strong, unpleasant smell or odor. And that can also be difficult for patients and for their family members to be around. It can be embarrassing for patients. And so there are strategies that we use often to improve, to improve the odor from these wounds so that people can be more active and be more social. Those are some quick examples. Hopefully that helps.
Thank you, Dr. Hunter. Thank you for your question, Nazmul Haq. And Ashraful Rahman asked another question. Patients needed palliative care needs more emotional and psychological support. But my question, why palliative care teams does not consist of any psychologist or any special attention to mental health status or support? Thank you, Ashrafur Rahman, for your question. So may I ask Dr. Catherine for answer this comment? Yeah.
Thank you, Leila. Well, actually, palliative care does involve psychologists where you're lucky enough to have them. And I know not all of you have access to psychologists where you work. In palliative care, knowing that many patients and families have emotional distress and some psychological distress, it's important that all doctors and nurses providing care for these patients and families have some skills in how to respond to emotional and psychological distress. And we'll be teaching you more about this later in the course. So we'll give you some skills to do this. Some patients do need more intensive support from a psychologist if available, but I know that's not the case for all of you. And I'd be interested if any of you want to write in the chat about whether you do have mental health support in your organization, because they are involved, they will be involved in delivering palliative care too.
Thank you, Catherine, for your nice clarification. Irene clarifies some wound issues that the other thing we can do for chronic wounds or pressure sores for those who cannot move or give ideas to the caregivers and families on ways to prevent them. To help with the tanning schedule every 2 hours, good skin care and hygiene, keeping the skin moisturized, offloading pressure points, and use the pillows and rolled towels. Thank you, Irene, for the wound care issues. We have the classes wound care later on, so participants don't worry about wound care. Yeah, and so Dr. Catherine says that there are team members in palliative care, but unfortunately in our country, Bangladesh, you don't say you don't see the team all the time, like psychologists, social workers, because we have we just started palliative care in our country, and we are trying to address this. Anthony says great points. I believe some palliative care teams include social worker and spiritual worker who often address the emotional and cultural aspects of patient palliative care and patient recovery. Thank you, Anthony. And Annie says that in the US, we have social workers who are licensed mental health providers. On our palliative care team, we have 4 full-time social workers. More on this in the another session, but great session. Thank you, Annie. From participants, do you have any other question? Do you want to share? You can unmute yourself and speak up.
No, I think there is no question actually.
Irene, clarify more about wound care. That wound care techniques that can be done at home will be taught in the course. Yeah, we will talk about the wound care later. Dr. Mridul says that no more question. Okay. Okay. So if you have, thank you for your question. We have to now move on the case presentation. Please continue to ask question in the chat and we will answer them in the chat as best we can. If there is time later, we'll try to answer them after the case as well. Now I would like to introduce our case presenter, Dr. Catherine, palliative care specialist. So over to you, Dr. Catherine. You have 10 minutes.
Thank you, Leila. Can I just check if everyone can see my screen okay?
Yes,
Yes, we
yeah.
can.
Great. So thank you. So thank you, Leila. Thank you, Dr. Hunter too. This is going to be really a continuation of some more of the ideas we've been talking about today and have been introduced by Dr. Hunter today as well. So we'll go forward with this. Please do continue to write any questions in the chat or share the questions after we go through the case. We'll have some questions for the group. Okay, next slide. So I want you just to think about these two questions, and Dr. Hunter also asked you about sources of suffering. So what are the causes for this patient's suffering, and how can palliative care help this lady? Okay, so I want you to think about these two questions as we go over the case. Next slide. So I'll share the case of a 35-year-old lady who has metastatic breast cancer, and she has a fungating malignant wound on her anterior chest wall with quite a foul odor. So this is something that we've already touched on briefly. She's very fatigued, so she's very tired, and she's willing to mobilize for more than a few meters now because she feels so tired and feels weak. Next slide. If you just go back one, Said. So to share with you some of her symptoms, she has pain, which is severe. And this is at the site of the fungating malignant wound, is what we call when the cancer erodes through the skin. So she has pain at the site of this wound in her chest wall. And that's due to the tumor infiltrating through her muscles, through the bones, through the nerves, and out through the skin. She is breathless, and this is thought to be due to lung mets, which were seen on. So the question is whether she might also have a pulmonary embolus on top. She's not able to sleep because her pain is severe, not only during the day, but also at night. And she's not able to walk as she was before, and she's not able to do the things she used to be able to do. So she's lost her mobility. She is low in mood, and she is anxious about her health and what is happening to her. This diagnosis was new. She was only given this diagnosis by her doctor 2 weeks ago. Next slide. So for most of you, you are working in within the camps or just outside the camps in Cox's Bazar. So similarly, this lady arrived from Myanmar, and she is staying in the Kutupalong area since 2017. Her husband, two of her children, also died before she became a refugee. She had 6 children. Her children with her now are age 7, 9, 11, and 14, so they're young. And she has 2 brothers also living in the camp in Kutupalong. Next slide. So this lady is Muslim, and her faith has been important to her. And when we ask her about her life and her experiences, she's always found the strength and hope from her role as a mother. And we asked her about how she coped with losses in the past, and including her husband and her children. And she shared with us it was by caring for her other children that kept her focused and kept her going.
Catherine, it's Gillian.
She does not know why this is happening to her at such a young age.
Catherine, your audio is a bit spotty. You slow down periodically. I'm wondering if going off video would help.
Thank you. Thanks, Gillian. Let's try that. Thank you. So she does not know why this is happening to her, and she's always had faith in her God, but she's struggling to understand how her God would allow this to happen to her after what she's been through already in life. And she's afraid of what will happen to her children after she dies. Can I just check my sound? Is that better?
Yeah, it's okay now.
Yes. Yeah.
Thank you. Next slide. Next slide, Said. So we'll just go back to those questions about the case. So what are her sources, what are this patient's sources of suffering, and how might palliative care help? So I'm actually just going to share again, apologies for that. I'll keep control, Said, this time. So I'm just going to share again this lady's physical symptoms, so you can have a look over those.
Can you show the
Catherine, we can't see your slides.
Thank you.
Anna has put it in the chat though, Catherine, so you may need to not, there you go.
see.
Thanks, Anna. So the questions are there. So I just want you to have a think about, Dr. Hunter spoke about the different types of suffering, so the physical, psychological, social, and spiritual. And I just want us to think together more specifically about what's causing suffering for this patient and how we might be able to help. And similarly, as Dr. Hunter says, there are no wrong answers. It's just really an exercise to start us thinking about approaching patients' symptoms and suffering in a different way to you might be used to approaching a patient's case history. So I want you to start thinking about what's causing this lady's suffering and how might be able to help. And I'm not asking for specifics on medications for help, but just what sort of things can we think about as a group. So please do go ahead and unmute, or feel free to write in the chat.
Thank you. So as the suffering side, we can mention that as we told about during the Hunter presentation, the several aspects of suffering here because of the bodily disease burden, social, spiritual, as going on, psychological. So there is the symptom that you were mentioned that the lady was diagnosed 2 weeks ago and she is in low mood and anxious. So it's the one of the panic cause due to she is tensed about her children's because of she has already husband was died before. So it's a very pathetic scenario for them. So their palliative care can help in several ways because of the symptomatic management is not the goal for the palliative care, as we know. So social support, spiritual support, and also the familial support is needed. But in this case that the lady has 4 children. So how can we help with the children? It's one of the very big issue, I think, this type of context in refugee situation. So we need to do a holistic approach by palliative care, thus we can support the lady for live stress-free life at the end of her life, actually, I think.
Thank you for that. And you're right, she's worried about her children. So we can think about how can we help her support the children. And you mentioned about holistic care and other aspects too. The one thing to mention is we can help her children perhaps now, and that might be in different forms in terms of direct support, practical support for the children. But we sometimes can help mothers who are anxious about what happens after they will die with planning about who she would like to be the children's guardian after death. And that can be a useful, it can be very useful to help reduce anxiety, to start talking and share and planning that together with the patient. Thank you.
Thank you, Dr. Katrin, for your excellent case. I would like to invite if there are any question from anyone to clarify the case. We can start to address the key question. Let's start this question. What are some ideas how to address this? There are no wrong answers. The point of this is to have the discussion and share our ideas. You can unmute and talk, or you can write something in the chat.
So sorry, Leila, I'll just read out some of the comments in the chat. So we have here from Mohammed Iftkar. She is, I'm sorry, it's come directly to my message, which is why you can't see it, Leila, so I'll read that out.
Yeah.
She's depressed about her disease and anxious about her children. Absolutely. So they are some sources of her suffering. And we have another comment here. Around stigma, maybe, yeah. And Ashrafa, I want you to mention a bit more what you mean about stigma in a moment, but stigma, economic issues, lack of a caregiver perhaps, because she lost her husband, and her children were all very young. Absolutely. Ashrafa, do you want to talk a bit more about stigma and what you mean by that?
Okay, thank you. In this case, social stigma, I just want to mean that in our many people may think that cancer or diseases may be the result of any our bad activities or like that. So in this case, as she is suffering from breast cancer, many people may think that before she did any bad work or like that. As a result, this is the result of like this disease or like cancer.
Thank you, Ashrafa. So that's very interesting to know. So there is a perception that maybe she's done something bad, and that's the reason that she's got the cancer. So perhaps there's a judgment around that and a stigma. That's very interesting to hear that. Another thing just to mention with the fungating malignant wounds is that sometimes there is the odor from the wounds, from the anaerobic bacteria that can grow on the fungating wounds, can produce a chemical which has a very foul smell. Not always, but sometimes. And sometimes that smell can be very strong, and it can really be a bit like a stigma as well, because it can mean people don't want to go in and see their person or give care to the person, and the person themselves can feel a lot of shame because they know that the wound is having a foul smell. So it's just something else to be aware of. And we'll learn more about wound care later, but we can use crushed metronidazole tablets to help with that smell if you come across it. So we have another comment here. We can ask her brothers to support the children. Yeah, and that might reduce her anxiety. Absolutely, that's a good thought. Sorry, that's come directly to me. I'm just going to ask you if you put the message in the chat, if you can just be careful to put to everybody so that everybody can read the comments. And there's another message that's come into me, which I'll read out. Sorry, Layla, you're not able to see these. We can counsel the woman at regular interval about her disease process. Yeah, absolutely. So we've talked a fair bit about her sources of suffering. I would like to ask you to write in the chat or share how you think palliative care may be able to help. We haven't talked much about her symptoms as sources of suffering, but does anyone want to share some ideas about how palliative care may be able to help? I know we've touched on a bit.
Hello, good evening. I'm Dr. Tawhid. About this scenario, I'll say as palliative care approaches a patient from all the aspects, including physical, mental, social, and spiritual. So we'll take one by one. As physical, and her main symptoms are now pain and the fun-jetting ulcer. So according to the guideline, we'll treat the symptomatic management of this patient, and especially if this patient is homebound, then the palliative care team can give her the home-based care, providing the regular wound dressing. And also for the ulcer, we could as we do the dressing in palliative care approach with normal saline, and as there is a very strong bad smell with metronidazole crust, we could do the dressing according to this. And also with the other parts like social part, as one of our colleagues said, the stigma, we could work on it and counsel the patient and her family members. And spiritual and social, we could do the counseling part and other things to relieve her stress and talk about the final prognosis of the disease and what she could do about the goals of care of this patient. We could arrange a discussion with the family members. So what's her and her family members plan for the disease. So yes, we could do this holistic approach for this patient, and we could set an individualized plan for this patient from a palliative care team. Thank you.
Thank you, Tawhid Mahmood, for your nice clarification. You talk about home-based palliative care, individualized care, and some symptomatic care, counseling the patient, and wound care. Okay.
I think Dr. Tawhid will be ready to invite you on the faculty for the next course, because I think that was a wonderful answer. I just want to highlight that. That was a very, an answer from a palliative care physician themselves, I think. Thank you for that. Thank you for sharing.
All right. Anybody else from the participants? Catherine, do you want to share something?
Well, I was just going to pose a few questions to stimulate thoughts. Does anyone want to share about some of her symptoms? If you remember, she had pain, breathlessness, lack of sleep. Anyone want to have an idea? I know we haven't covered these yet, and we will be covering these in the coming weeks, but just to share a few ideas about what we might be able to do to help some of her symptoms, her physical symptoms.
Anyone?
Can you repeat the question, please? Actually, didn't hear clearly.
Layla, do you want to repeat it in English and also in Bangla, because my audio is not good?
Okay. The question is, the more about physical symptoms and how to address this, why they are causing the pain, more about pain, breathlessness, and insomnia, and the other symptoms the patient have, and why this is happening, and how can we help about the physical symptoms.
So we can hear palliative care here can give the symptomatic support also, and pain relief, and also there is some there is some psychological symptom also, though she is low in mood. It's the maybe sign of her depression. So there is some psychological support also that she need, because of she's worried about her future and thinking about her children. So it's a depressive feature, some sort of. And in case of there is the physical condition, we give the supportive treatment. And also, if it is though there is mentioned already, it's not in a curable stage, so try to, there is some several modalities like metastatic cancer, in we can provide the radiotherapy, so which can enhance the life. So that's it, I think.
Thank you, Dr. Mridul, for this. And to talk about radiotherapy, yeah, Catherine, yeah.
Oh, sorry. Go ahead, Leila, if you want to ask one of the faculty to answer that, or go ahead with that question first, and then I'll...
Yes, Dr. Mridul says about the role of radiotherapy in the metastasis. So I want to ask any of the faculty if you are answer the question. Go ahead.
Hello.
Yes, Dr. Ashafur. Yeah.
Yes. My observation in this case, especially to improve her physical symptoms, can we advise him something to do some limited exercise or like that?
Can I just jump in, Leila? Is that okay? I just want to, in terms of exercise, first, sorry, to answer your question, Ashrafa, thank you. It would really depend on her goals, on the patient's goals. And if trying to improve her mobility and her energy level and what we call physio or rehabilitation was something that was in her goals and something important to her, then yes, yes, we can do that. And this is part of the individualized care that we try to offer for our patients. She may be too fatigued for it, but if it's something important, you can try just gently, approaching that very gently. Just one comment about the, there was some good comments shared about managing the symptoms. And I just want to say something more. So when you have a patient who's in severe pain, the pain can affect and cause other symptoms as well. So the first approach to thinking about the insomnia and thinking about the low mood is to actually first treat the person's pain, because we know that having severe pain can impact on a person's capacity to sleep. And we know it can make someone feel very low in mood as well, to be in pain. So we always treat the pain as a first step and see if that improves the sleep and the low mood. Now, some people might be very depressed and also need an antidepressant early on while they still have pain. But just as an approach, sometimes treating the pain helps you with some of the other symptoms as well.
Thank you, Catherine. Dr. Tasnim says radiotherapy and chemo are not available in Cox's Bazar, and patient has to visit Chittagong district to avail this, which take almost 5 hours journey by road from Cox's Bazar. Thank you, Dr. Tasneem. Dr. Mridul says radiotherapy is not available in Cox's Bazar, but if needed, may we send the patient to Cox's Chittagong? So
Leila,
I think, yeah,
can I make a
Dr.
comment?
Hunter. Yes,
Just to,
please.
I think that something that Dr. Catherine said a minute ago, I think is really helpful and important to keep in mind as we talk more about palliative care and specific palliative interventions for patients, which what she said was, it's really important to know what the patient's goals are, because that can continue to help us figure out what is the best approach to improve a symptom or to offer a treatment. An example, I think the question about radiotherapy is a good one here, because in this case, because it makes me think about if the patient's goal is to be cured of her cancer, radiotherapy is not going to help with that. And going, to Chittagong is not going to be an effective approach to reach that goal if that's her goal. If her goal is pain management or more function, maybe something like that might be helpful in some cases. Radiotherapy for a malignant wound like Dr. Catherine is describing. But most importantly, when we really get to know the patient and the patient's story and understand the context of the illness, then we might start to understand that the patient perhaps has a more important priority, which is to be at home as much as possible, or to be around her family as much as possible. In which case, then radiotherapy, going to, on a 5-hour trip to a different hospital doesn't sound like the best idea for that goal. So having that conversation and understanding the patient's goals, all in the context of these different options, is really, really important, so we can help the patient make the decision that's best for her and her family. I hope that helps, but I think really thinking about specific goals that are individual to the patient is really a big part of the work that we do.
Thank you, Dr. Hunter, for your answer in the radiotherapy. So this is for practical. We need to think more about the individualized patient care, and we have to think that what is the condition and is it curative or not. So we need to think about the pain management and the symptom management first. So any comments from the other faculty members?
In terms of this woman's suffering, I think that as a practitioner, a healthcare practitioner, and hopefully everyone that's on this course at some point will become a palliative care practitioner, I think it's really important also to see how your emotions are in the situation, given how severe the wound was and the amount of suffering that she has gone through with not only being a refugee, but the amount of loss that she's already experienced. Thinking about that and reflecting on that as we treat her. We obviously can't take on the pain that she is experiencing, but it's going to be a very complex case. So if there are other people in your vicinity or in the clinic, or even through this ECHO, this course that you can reach out to while you're caring for these really complex cases, I think that's something that we even touched on earlier. Our teams in Bangladesh might not be very big, but it's really important that you don't try to take on these complicated cases on your own. Even, of course, if no one is physically with you, to reach out virtually through the WhatsApp chat or the calls like this that we're having. Because these kinds of cases, you can kind of feel overwhelmed, and then you may not be able to give your best. And you might not be able to focus on the needs of the patient because her whole story is really overwhelming. So that's just one other thing I wanted to mention. When we come across these patients that are suffering in many different dimensions of their life, that we shouldn't be taking them on by ourselves.
Thank you, Erin. Okay. So anyone can ask any comments, question or comments from faculty members or participants?
Can you hear me?
Yes, we can hear you.
Okay. I think this lady is early diagnosed. If the patient who is suffering from the breast cancers and the patient is early diagnosed, and this type of patient, I think if we do mastectomy, and that's times it will be helpful for these patients. And if we do regular dressing and we do symptomatic treatment, and that's like pain management, and also there is the most effective the psychological support. I think this will be helpful those type of patients.
Yeah.
Thank you, Nesmal, for your comments. I agree, psychological support will be very helpful, and managing the pain and the dressing will be very helpful. I'm going to disagree with you about a mastectomy. It's too late. It's too late. This lady has locally advanced cancer, metastatic cancer, and if you do a surgery, it's likely she may develop another wound that doesn't heal and more pain. So I would say I agree with all of your points apart from the mastectomy. This will be something that would not be in her benefit, but the dressing care and the psychological support, absolutely, very important. Thank you. Thanks for sharing.
Okay. Yeah.
Hello?
Yes, we can hear you. Go ahead.
Okay. In this patient, besides patient, I think special attention also needed for the children, and special counseling and support also needed to the children, because they are very young, and it will make a mental trauma to them. So I think very special attention and psychological support also needed for the children. And I think it's very needed to clear them the probable causes of the disease and probable fate of the disease, because to remove also the social stigma. I think this also very important in this holistic care. Thank you.
Thank you, Ashrafur Rahman. Yeah,
So I have one opinion that in
yes.
in the term of when talking about the mastectomy, so can we say that it's totally not important? But if we are considering the extensive or the metastasis of the this persisting cancer, perhaps it's maybe helpful if it is in early stage. But if it's on later, so it not might be grateful for her. So symptomatic management and the wound care management and so on, or holistic approach is actually important. But in the term, if that's very initial, then we can consider the mastectomy is also unpreferable. Does help her life to enhance, I think. So I need opinion my faculties for this purpose, I think. So make clear to all, it helpful for everyone.
Absolutely. Yeah. Dr. Catherine, do you want to comment in this?
Sorry, I just missed some of that, Dr. Murdal. Was it to ask about, were you asking more about the clarification on the mastectomy
Yes.
and whether that should be?
Yes, Katrina, I just talking about that that if we are talking the term of the mastectomy, when it's talking about mastectomy, so if the if the neoplasm is in very early stage, then the mastectomy will be the preferable, I think. But if this is already metastatic extensively, so then it thought will be the preferable step because of it's already spreading. So we cannot do anything much more to doing mastectomy. It's one of the extra burden for the patient. So then we have to learn about the patient psychology and patient demand also. But if in early stage, then the mastectomy has the very good role to enhance the life of the patient. So I need clarification regarding this mastectomy, that when we are need to do that and when we are not go for that. May I clear that? Is it
Sure, yeah, that makes sense.
Yeah,
So
thank you.
mastectomy is really is really a treatment for breast cancer which is curable. Okay, so when you have breast cancer and that's early stage, limited to the breast, and to the best of your knowledge, it hasn't spread, and then mastectomy may be an option. But if you know the patient has metastatic cancer, and certainly when you have a fungating malignant wound, which is when the cancer has eroded through the chest wall into the skin and opened up the wound, there will not be any benefit from doing a surgical procedure. In fact, usually for these patients, you risk doing harm. So mastectomy has a place for breast cancer in early stage, but it's too late when there's metastatic breast cancer, and it won't have a benefit because you can't remove the cancer.
Yes,
does
yes,
that
it's
answer the
clear.
question?
Yeah. Yes, I just exactly. I just wanted to know that this actually because of it cleared the confusion regarding our some of I think everyone, that is the if it's metastatic already, so there it's helpful to do not do mastectomy because of it makes the only disease burden increase for the patient and also family in every situation, not in the refugee context and also in the other context because of its increase the burden. Thank you.
Yeah, just to clarify very, very briefly, occasionally there are indications for a surgery, which may not, I'm not talking about mastectomy in particular here, but if you have occasionally, if you've got a metastatic cancer, you may do the surgery, but not to cure the disease, but it might be to help with symptom control. Occasionally you do a small surgery, but with a fungating wound, never seen it. I that's not usually the management. And in the most part, it's a don't do. Of course, in medicine, there's no absolute, and but to keep it as simple as possible, then that would be the situation. Thanks so much for asking. It's a very good point.
Yes.
And just a reminder, you can always ask for support through your different networks via us, via phone, before you just send patients, so that you try to minimize the burden for the patient, to get a plan for the patient without sending them from one center to another until you're clear if something can help. I'm not suggesting you will do that, but it can just help. Think about, what am I putting the patient through to send them to this hospital? And can I do this? Can I find out about this without sending the patient, and try to do some background understanding and limit the burden for the patient? Thank you.
Yes, thank you, Catherine. Dr. Tasneem, you want to share something?
I just want to add something, Laila. Thanks, Dr. Mridul, for asking these questions. I think many of us, we are having the same thoughts, but thank you for pulling up this agenda. Let's try all together, especially in the Rohingya camp. Once you get such cases, we will discuss many cases in coming session. And this one is already written, it's a fungating wound. And we can understand that patient is not in a very good stage to send for mastectomy or in Cox's Bazar or Chittagong. But what do we do? What I have seen inside the camp, that let's get a patient diagnosed with cancer, send it to Cox's Bazar or Chittagong. We can't do anything here. That could be something that we can work with palliative care approach, what can be done for this patient and what this patient is willing for. That's how we can address. This is I wanted to add. Thank you.
Yes, Tasneem Babu, exactly. I want to say that before it's one of the very bad psychosis among the camp, because of if we are getting this type of patient and then we send it to the Cox's Bazar or try to be tissue on a Chittagong, that it's needed. But we have to identify we need the patient what they need, and in this type of situation, yes.
Yes, please.
Yeah.
So in this stuff, if a patient has no option of surgery. So I just want to say that. Thank you, Apu.
Okay.
Thank you, Dr. Medul. I see it as a competition that let's send the patient right now to Cox's Bazar or Chittagong. It should not be here. He or she should not be here. So this should not be the palliative care approach. Thank you.
Yes, yes.
Thank you all participants and faculty members for all your inputs and discussion today. Now I want to ask Dr. Tasneem about a brief Bangla summary of our today's session.
Thanks, Laila Tulapa. No wonder this is the most interesting part for Bangladeshi participants here to hear in Bangla. Okay, I'll be very brief. আসসালামু আলাইকুম, আপনাদের সবাইকে ধন্যবাদ এতক্ষণ পর্যন্ত ধৈর্য ধরে এই লেকচারগুলো শোনার জন্য। আমাদের আজকের বিষয় ছিল প্যালিয়েটিভ কেয়ার কি। ডক্টর হান্টার খুব সুন্দর একটা লেকচারের মাধ্যমে আমাদেরকে বুঝিয়েছেন। প্রথম আমরা যেটা দেখেছি, খুবই টিপিক্যাল একটা কেস আমরা দেখতে পেয়েছি, সিওপিডির একটা কেস নিয়ে কথা বলা হয়েছে, এবং আমি মোটামুটি নিশ্চিত ডক্টর এবং আদার্স হেলথ কেয়ার প্রফেশনাল যারা রয়েছেন সবাই চিন্তা করেছেন যে সিওপিডির জন্য কি কি করা যায়। তারপর ডক্টর হান্টার আমাদেরকে তার ফিজিক্যাল সিমটমের পাশাপাশি আরো কিছু বলেছেন। আমরা যদি সাইকোসোশ্যাল ব্যবস্থাপনাগুলোর দিকে যাই, তিনি একটা শেয়ার্ড বেডে থাকেন এবং তার দুজন গ্র্যান্ডচিলড্রেন আছেন এবং তারা বস্তিতে থাকেন। প্রতিবারের ভিজিটে উনি কাঁদেন, কিন্তু কি কারণে কাঁদছেন সেটা বলতে পারেন না। সুতরাং এটার ক্ষেত্রে আমরা কিছু গ্যাপ দেখতে পেয়েছি, যেমন তার কি কি সমস্যা রয়েছে এটা পুরোপুরি বুঝতে পারাটা, আমাদের কথা বলার স্টাইল বা আমাদের সময় দেওয়ার স্টাইলে কোনো গ্যাপ রয়েছে কিনা সেটা নিরূপণ করা, এবং সে আসলে কোথায় সেবা নিতে চায়, সে কিভাবে থাকতে চায়, এবং এই রোগটা কেন হচ্ছে এই বিষয়টা যেমন আমাদের কাছ থেকেও জানা নেই, তাদের কাছ থেকেও সেভাবে পরিষ্কার নয়। আরো একটা জিনিস আমরা দেখতে পেয়েছি, পরিবারের দিক থেকে কি কি গ্যাপ রয়েছে। যারা এই ধরনের রোগী, শুধুমাত্র সিওপিডি কেস না, এই ধরনের প্যালিয়েটিভ কেয়ার রোগীদেরকে যারা সেবা দেন, যাদের বাড়িতে তারা অবস্থান করেন, তাদের পারিবারিক সদস্য যারা আছেন, তাদের ক্ষেত্রে দেখা যায় ইমোশনাল সাপোর্টটা তারা ঠিকঠাক মতো পান না। ফিনান্সিয়াল বার্ডেনের কথা বলা হয়েছে, এবং অবশ্যই কোথায় থেকে তারা সেবাটা নিতে চান। আজকে আবারও WHO অনুযায়ী প্যালিয়েটিভ কেয়ারের ডেফিনেশনের কথা এসেছে। আমরা 4টা অ্যাসপেক্ট নিয়ে আগেও কথা বলেছি, আজকেও কথা হয়েছে সেটা কিরকম হতে পারে, সেটা থেকে কি ধরনের ডিস্ট্রেস ডেভেলপ করতে পারে। এরপর আমরা আজকে খুব মোটা দাগে একটা জিনিস শিখেছি, সেটা হচ্ছে কাদের প্যালিয়েটিভ কেয়ার দরকার। ডক্টর হান্টারকে ধন্যবাদ যে আমরা কিছু ডায়াগনোসিসের ব্যাপারে দেখতে পেয়েছি, এবং ওল্ড মডেল এবং বর্তমান মডেল যেটা চিন্তা করা হচ্ছে প্যালিয়েটিভ কেয়ারের ব্যাপারে, যেমন একটা রোগ হওয়ার সাথে সাথেই প্যালিয়েটিভ কেয়ার পাবে নাকি মৃত্যুর আগে আগে পাবে, সেই ব্যাপারটা নিয়ে আলোচনা করা হয়েছে। বৈশ্বিক এবং বাংলাদেশের কিছু চিত্র তুলে ধরা হয়েছে। বাংলাদেশে বছরে প্রায় 6 লক্ষ লোকের প্যালিয়েটিভ কেয়ার সেবা প্রয়োজন, এবং তাদের ভিতরে 2 লক্ষ মানুষ হচ্ছেন ক্যান্সারে আক্রান্ত। খুব সুন্দর করে কিছু রোগের নাম বলা হয়েছে, যে রোগগুলো থেকে আমরা বুঝতে পারবো যে এদেরকে আমরা প্যালিয়েটিভ কেয়ার সেবা দিতে পারি। আমরা ক্যান্সারের কথা শুনেছি, স্ট্রোকের কথা শুনেছি, প্যারালাইজড হয়ে বেডে পড়ে আছেন এরকম রোগীর কথাও শুনেছি। কিভাবে আমরা প্যালিয়েটিভ কেয়ার দিব, হাউ টু প্রোভাইড প্যালিয়েটিভ কেয়ারের ভিতর বলা হয়েছে আমরা সিমটম কন্ট্রোল করব, ডিজিজটাকে ম্যানেজমেন্ট করার চেষ্টা করব, এবং আমরা কিছু কমিউনিকেশন, কাউন্সেলিং এবং কেয়ার প্ল্যানিং করব, যেটার ধারাবাহিকতা আমাদের পরবর্তী কেসটাতেও এসেছে। আমরা কিভাবে দিতে পারি, কোন জায়গায় প্যালিয়েটিভ কেয়ার দেওয়া যায়, শুধুমাত্র কি হাসপাতালেই প্যালিয়েটিভ কেয়ার হয় কিনা সেই ব্যাপারে জেনেছি। আমরা কমিউনিটি বেসড প্যালিয়েটিভ কেয়ারের ব্যাপারে জেনেছি, হসপিটালের কথা শুনেছি, হসপিস যেটা আমাদের দেশে খুব কমন নয়, এরকম কিছু বিষয় নিয়েও আমরা আজকে জানতে পেরেছি। এরপর আমরা একটা কেস প্রেজেন্টেশন দেখেছি। আমার মনে হয় আপনারা সবাই একমত হবেন যে এরকম কেস আমরা স্বভাবতই দেখে থাকি, এবং আজকের প্রশ্নগুলো ছিল যে এই রোগীর কষ্টগুলো কি কি এবং প্যালিয়েটিভ কেয়ার কিভাবে তাকে সাহায্য করতে পারে। আমাদের আলোচনায় বেশ কিছু বিষয় উঠে এসেছে, কেন রোগী পেলেই শুধুমাত্র আমরা রেফার করে দেওয়া অথবা অপারেশনের দিকে যাওয়ার কথা ভাববো না, আমরা আগে ভাববো যে রোগী কোন অবস্থানে রয়েছেন এবং তার জন্য কি করা সম্ভব। আমরা সিমটমগুলো সম্পর্কে শুনেছি, আমরা নেক্সট লেকচারগুলোতে অবশ্যই কভার করব ব্যথার জন্য কি করতে হবে, ব্রেথলেসনেসের জন্য কি করতে হবে, এবং আরো যে এই সিমটমগুলো একজন প্যালিয়েটিভ কেয়ার রোগীর ক্ষেত্রে আমরা পেতে পারি, প্যালিয়েটিভ মেডিসিন অনুযায়ী আমরা কিভাবে তাকে সেবা প্রদান করে তার জীবনযাত্রার মানকে উন্নত করব। আমরা এই রোগীটার সোশ্যাল হিস্ট্রি সম্পর্কে শুনেছি, একজন মহিলা যিনি অলরেডি তার হাজবেন্ডকে হারিয়েছেন মিয়ানমার থেকে আসার আগেই, তার 6 জন বাচ্চার ভিতর 2 জন বাচ্চাকে হারিয়েছেন, তার মাথার ভিতর অনেক কিছু চলছে যে কেন আমার সাথে এরকম কিছু হলো। আমি খুব সুন্দর একটা পয়েন্ট অ্যাড করব ডক্টর ক্যাথরিনের পক্ষ থেকে, যিনি বলেছেন যে তার এতখানি চিন্তার অনেকখানি অংশ জুড়ে রয়েছে তার সন্তানদেরকে তিনি কোথায় রাখবেন বা উনি মারা যাওয়ার পর তাদের কি হবে। আপনারা দেখেন তার দিক থেকে উত্তরটা একই ছিল, আমরা কিন্তু প্ল্যান করতে পারি যে তার কাছে কোথায় সেফ মনে হচ্ছে, এবং সবশেষে আমরা এই প্রশ্ন দুটো আবার করেছি, এখানটায় কোনো ভুল উত্তর নেই, আমরা নিজেরা জানার জন্য যে আপনি এই রোগীর জায়গা থেকে কিভাবে চিন্তা করবেন। আমি শেষ করব শেষ একটা স্লাইড যেটা ডক্টর হান্টার আমাদেরকে দেখিয়েছেন। প্যালিয়েটিভ কেয়ার ইজ আ মিশন, প্যালিয়েটিভ কেয়ার একটা মিশন। এখানে বলা হয়েছে গো অ্যারাউন্ড, আপনি যাবেন এবং দেখবেন আপনার আশপাশে কোথায় কি হচ্ছে, এবং এই কোথায় কি হচ্ছে সেটা থেকে মাল মশলা নিয়ে আপনি নিজের একটা ভার্সন তৈরি করবেন। There is need of diversity in this field. ডাইভার্সিটির খুব ভালো বাংলা হচ্ছে বৈচিত্র্য। আমরা যা কিছুই করব সেটার ভিতর বৈচিত্র্য থাকতে হবে। ছোটবেলা থেকে আমার বৈচিত্র্য খুব বেশি পছন্দ, সবাই যেরকম করে সেরকমটা করলে কিন্তু সেটা আমার জন্য হবে না। আপনারা যারা হেলথ কেয়ার প্রফেশনাল আজকে এই সেশনটিতে ছিলেন, আমি বলবো আমরা এই লেকচারগুলো দেখবো, জানবো, এরপর আমাদের একটা ভার্সন তৈরি করার চেষ্টা করব, আমাদের একটা বৈচিত্র্যময় ভার্সন, অথবা প্যালিয়েটিভ কেয়ার বাংলাদেশে কিরকম ভাবে হতে পারে সেই ব্যাপারে আমরা চিন্তা করার চেষ্টা করব। ধন্যবাদ।
Thank you, Dr. Tasni, for your nice Bangla clarification. Thank you all for joining today. Thank you, our presenter, Dr. Hunter and Dr. Catherine, for your nice presentations today. And here are the next session presentation. Our next session will be at 8:30 p.m. at June 18 on the topic of opioids and pain management, local opioids accessibility and availability in Dhaka, Bangladesh and Rohingya camp. So thank you and goodbye. We will share the video recording and key learning points by email and WhatsApp in the next new few days. So ভালো থাকবেন সবাই। See you in the next class.
ধন্যবাদ। Bye.
Bye, everyone.